And with that reminder, we'll get started. Welcome, everyone. I'm Anthony, the nurse liaison for the Virginia Impact Project, Virginia Department of Health funded initiative to help bolster infectious disease preparedness across congregate care environments in the Commonwealth of Virginia. This is our final webinar for 2023, so we're excited to tie things together with this final webinar. And just wanted to welcome everyone. It's great to see some folks who have attended each webinar on reliably, and it's great to see some folks show up session after session. And just kind of a reminder of our background, the webinar series and developing a community of practice through the webinars is one of our areas of focus. The other area of our that we really are focusing on at this point that's developed over the past few months is telehealth optimization across congregate environments in Virginia. And so we are pursuing and engaging congregate communities to help optimize their use of telehealth. And the idea being that helps to contribute to the infrastructure for infection control across the state. So any questions or any commentary with respect to that area of focus of our project, I'm happy to take any emails and follow up with you promptly after that, and I'll post that in the chat. But without any further delay, I'm going to hand off to our medical director, Dr. Laurie Archibald-Pannoni, and she'll get things started further. So thank you for coming.
Thank you, Anthony. It's nice to see everyone here today. Thank you for joining us. Those of you who've been with us over the past few months, and those of you who may be new as well, we're excited to have you all. We're wrapping up 2023 with a special presentation from Dr. Dallas Nelson. Dr. Nelson is joining us as a professor of medicine from the University of Rochester in the Division of Geriatrics and Aging. She's a certified medical director and a fellow in the American College of Physicians. She's a medical director of the UR Medicine Geriatrics Group, a group that serves about 3,000 patients across the spectrum of long-term care in the Rochester metro area. She also serves as medical director of nursing home and in assisted living facilities. Dr. Nelson is a primary care physician for residents in and across the long-term care continuum. And she's the immediate past president of the American Board of Post-Acute and Long-Term Care and the New York Medical Directors Association. Dr. Nelson's main interests are improving healthcare delivery to the frail older adult and educating practicing providers in geriatric medicine. So with that, we are very honored to have you join us today, Dr. Nelson, and I will pass it on to you.
Thank you very much. And it's really exciting for me to be with you all. Just trying to get this to advance. There we go. What I'd like to do, in practicing for this talk, sometimes I found myself using I and we or whatever. I am coming to you as a medical director who's been doing this a while and has confronted many infection control conundrum, and also gotten the opportunity to work on some projects to help our community get better. So I wanted to share some of what I've learned about how to work with my infection control partners within the nursing homes and try to optimize the infection control in the building. Let's see. Oh, so I have no actual or potential conflicts of interest with relationship to this presentation, and my learning objectives are to describe whose role it is to help with infection control and antibiotic stewardship in the nursing home setting. I would hope that you'd be able to list how do you meaningfully engage with the medical providers by the end of the presentation, and also be able to explain how to facilitate that collaboration with your medical team. So the IP nurse and the duties, they are big and important. in the nursing home. You're in charge of making recommendation for prevention infection control, advising your staff on the management of infections and prevention issues, coordinating with the annual infection control risk assessment with the IDT, developing an annual infection control plan, evaluating the plan for goal achievement, conducting surveillance for infections, ensuring completion of audits. Oh my goodness. The providing education and training for all the staff and independent providers, working with the employee health nurse, liaisoning with the medical clinical teams with standards, audits, research, and also presenting and providing infection prevention annual reports and working through the QAPI program, and collaborating with the county and state health departments on infectious disease and communicable disease reporting. So that's a lot. And you're really a very important leader in your building. And you're part of the whole program for preventing and controlling infections in your building, but you're going to need to, you can't do it alone. I just read all of that in part to reinforce that you cannot do it alone, and you're going to need to partner within your facility and to do all of these steps in engaging your team, assessing risks, developing plans, interventions, changing how you do things, which of course we all know that's not very easy in a nursing home. So there's a ton of work, and you can't do it alone. And in fact, you're really trying to influence that the care that others are providing. So we need to partner in doing that. And how do you? The medical team is clearly part of the teams that you need to communicate with. And how do they help with infection prevention and control in the nursing home? And which of the medical providers can help you the most? Now, I would argue that your medical director ideally is the person that can help you. That's kind of in their job description. That being said, I also understand the variability of nursing homes, and sometimes the medical director is not the clinical leader. So if that's the case for you, then think of it as maybe it's an NP or PA who's genuinely doing the work of clinical lead. But whoever your clinical leader is, and ideally it's the medical director to help you. And also, so the first thing we'll talk about is antibiotic stewardship. So ultimately, while patients and families and nurses and outside providers have inputs into this prescribing sort of patterns, the medical providers are ultimately the ones who write the antibiotic prescriptions. So they need to be a focus of our attention on how to steward our antibiotics. So, and the medical director can help with these things. So what they can do is they can help with antibiotic use criteria, antibiotic selection, and antibiotic follow-up, and days of therapy and selection, and renal dosing. So I wanted to let you know we were part of a collaborative here in Rochester, New York. It was led by Rinma Dunyati, who's an ID doc, and she was charged by the New York Department of Health to decrease C. diff infections in our community, and including the long-term care continuum. And so she partnered with the different nursing homes, learned a lot about the nursing homes, because there's a lot of hospital folks who don't necessarily know about nursing homes and how it works. So she went in and made sure she understood how it works, and then ended up partnering with many of the community medical directors to establish these sorts of criteria for our community. And I'm going to share some of that work with you and how we did some of that work. One of the things that's written into the infection prevention literature is knowing about your antibiogram. Antibiograms aren't something that everybody sees regularly. And then actually, it's hard to get one. You can, if you had a very, very large facility, you may be able to create your own antibiogram, generally only successfully on urine cultures in our nursing homes. But more likely, you may have to liaison with your lab and look at maybe if they've sorted out what the antibiogram is for nursing homes or just for your community. But the antibiogram is essentially what antibiotics effectively treat what bacteria. And so you can see I have an old antibiogram that we had from 2017 to 18. And in our community, although many people use ciprofloxacin to treat urinary tract infections, you can see at the top line here for E. coli, which is our most common urinary pathogen, the ciprofloxacin was only effective 71% of the time. Whereas we had with the nitrofurantoin, we had a 98% efficacy. And with cefazolin, we had an 84% efficacy. So that very heavily influenced some of our antibiotic decisions. We also knew that C. diff colitis has been very associated with the use of quinolones. And in our community, we had gotten in a habit. One of our doctors had done research and said that we should all be using moxifloxacin for in the nursing home for pneumonia. And so we were using a ton of quinolones at the time. And so Dr. Giumiotti and all of us got together and we started to collaborate around which antibiotics were most effective in our community and which ones were most associated with the C. diff colitis. So this is something that should be useful to you if you can get your hands on it. One of the other things I want to say is that a medical director generally would be able to interpret this and then come up with some maybe localized recommendations for triaging what antibiotics should be empirically used within your buildings if you don't have the sensitivity data in a clinical situation. So in our collaborative in Rochester, we actually came up with a bunch of tools. You can see the website for it and understand this is Rochester specific using our antibiogram, but some of the other tools, you can use them. They're useful. And so the website's rochesterpatientsafety.com. We came up with educational materials. And so we worked with education materials and to tell essentially families, because a lot of people have pressures around antibiotic use and a lot of pressure to use antibiotics for very questionable reasons. So we created pamphlets and educations. We liaisoned with our emergency departments to give them a smart phrase to use when it didn't meet criteria for a urinary tract infection. We came up with tracking tools for antibiotic use, and I'll show you more about those later. And then we also came up with guidelines for treatment of infections in our buildings, urinary tract infections, pneumonia, and soft tissue infections. And some of them were more helpful in the sense that soft tissue infections, if you didn't differentiating between what would be a strep versus a staph, and some of the other tools for knowing when to treat COPD with an antibiotic versus not treat COPD with an antibiotic, and also just guidelines on waiting on urinary tract infections. So many of those have been very helpful. I use them with my IP. We use all of these different guidelines. We agree that this is our ideal. My IP is able to see whether the medical providers are adhering to our guidelines also. And they're also able to use some of the materials, tools to educate others, family members and staff about appropriate antibiotic use. I wanted to touch base on some of the criteria that we use in the antibiotic stewardship programs. And so many facilities, at least where I'm around, have decided, because the regulations said that we needed to choose a criteria to say whether we are appropriately using our antibiotics. So many of them have chosen the McGeer criteria. And I have always been uncomfortable with that. The McGeer criteria, many of you are familiar with it, but it requires several symptoms and different ones for if you have a catheter. But at the end, it also includes whether you have positive culture. And so what's confusing as a clinician is understanding what the culture results are days before you get those results, right? So how do you use that in a clinical setting when you're looking at a patient who may or may not have a urinary tract infection? Because generally speaking, we just don't have all the pieces of the McGeer criteria available. So I would advocate that the McGeer criteria is good for understanding the rate of genuine urinary tract infections in your building. So it's good for understanding in the end what your rate of urinary tract infections are, but it is not a good, its utilization is poor for giving feedback to clinicians. You will meet with resistance when you do use the McGeer criteria at clinicians because it doesn't, as I said, it doesn't make sense to the clinician how they could use it because it's a retrospective review. So I would advocate for when you're giving feedback to the provider using lobe criteria, and that's one of the other listed criteria for assessing a urinary tract infection, and that is based. And the main difference on the lobe criteria is it doesn't have culture results already available. So this is more in keeping with how we would decide in the moment, whether with the acute, dysuria and fever and another symptom. That would be more keeping with our criteria. But truth be told, both of these, the McGeer criteria and lobe criteria, poorly report what I would call the fog of war in a nursing home, which is that very sick person who's in front of you that you are worried is potentially septic, and you don't want to miss the window of meaningful treatment. So I actually find this algorithm, which acknowledges that some patients are very sick. You don't know exactly why they're sick, but they seem almost septic. And in this algorithm, they're called the warning signs. And the warning signs are a fever or an increase of temperature from baseline, rigors, acute delirium, or unstable vital signs. So if you have warning signs, then this algorithm would endorse going ahead and treating. So, and I'll walk you through the algorithm a little bit. So you have a resident with change in condition, and they do have localizing urinary tract signs and symptoms. You would go ahead and get a urine culture because they've already met the criteria of like in the lobe or the beginning part of the McGeer criteria. Then you go ahead and get a UA and urine culture. And if they have warning signs, then you go ahead and treat. Because you're trying to avoid transitioning to sepsis. Now, if there are no localizing signs, then you would go ahead and just do a bigger workup. The patient's changed and you need to have a broader differential diagnosis outside of just urinary tract infection, because many of us have functioned in a world where everybody jumps to urinary tract infection with any sort of change, and you're going to miss important things like hyponatremia or MIs or pneumonia, if that's the case. Now, if the patient doesn't have warning signs and you can get a culture, and if they do have warning signs, you can also get a culture, but if they don't, even if they don't have localizing symptoms, because you're not sure where that infection is coming and you just would like to get the culture before you go ahead and use antibiotics. If they don't have warning signs, you can observe the patient. We call that expectant management. And we document that, and you can actually set up a protocol within your building for expectant management, where you are going to watch vital signs, you're going to look for localizing signs. And many people with a little bit of pushing of fluids will never develop any further changes, and no antibiotics are ever necessary, or no urine signs, non-urinary signs show up, and you'll treat whatever that cause is, or ultimately you get some culture that comes back if you've got some urine signs. So I like this algorithm. I thought it was a sensible way to approach your patients, because it does acknowledge. And I think that if you have an algorithm like that to discuss with your medical team, you're going to get a better response. There was an interesting article in JAMDA this month about the difficulty of these the Loeb criteria and the McGeer criteria, because they do fail to acknowledge the fog of war, and they fail to acknowledge past history of patients, past other things, and so you're always going to have a bit of difficulty with your medical providers, because there is context that those criteria don't have. So you need to keep an open mind. But one of the most important parts is when you are putting out an antibiotic stewardship process, you need to make sure there is a process, a known algorithm, like I was suggesting, for how to evaluate the appropriateness of starting an antibiotic. And that appropriateness should not be retrospective, which what I was arguing, that the McGeer criteria is very retrospective, but you need to be looking forward. And then your medical staff can adhere. Now, many buildings, I have rarely had the facility come up to me and talk to me about the urinary tract infection algorithm, but that needs to be done. It needs to be talked about and openly with the medical providers. I've liked to post the algorithms on the wall. I like to post them so that they're there for reference. The guidelines that I talked about, I will encourage people to keep them in a very handy spot. But all the components of an antibiotic stewardship program need to be explained. We in many of our conversations, we've talked about the difficulty when a person is short of breath and hypoxic. The differential is broad, but the clinical scenario is quite serious, and very frequently it is difficult to rule out a pneumonia and stay within the response time. So you have other things like shortening the duration, stopping it when the clinical picture changes. So you also need to explain the antibiotic timeout procedures and limiting duration, and there, and then leave consideration for other factors. So when I review the antibiotic use and I see somebody who I don't understand why they went ahead to use antibiotics, I will talk to the clinician as the medical director, as a peer clinician, and say, well, why did you decide on that patient to use the antibiotics? And I allow it to be a well thought out clinical decision is an acceptable one. One of the ways I have asked my IPs, they should review all of the antibiotic use in the building. When somebody's antibiotic use is not adhering to our previously set out standards, they should alert the provider that it is not adhering, and then the provider should be prompted to review the case. And then I've asked the IP to just let it drop from that point, because the ones I saw really negative reactions on the part of the providers when they were having to explain themselves all the time to the IP. I think that raising awareness can be absolutely sufficient. So that's where this is the process that I set up in my buildings, where the IP will gather the data, we will review it, And then I will take anything that is questionable as the medical director and review it with the team. And truth be told, medical providers generally can review their own data. If they are an outlier, they will see it very quickly. And they don't want to be an outlier. And you don't really have to say too much. I had really my first medical director gig, and my first lots of decades ago, when I would go into the nursing home and they would have a stack of urine cultures. And I was like, oh boy, right? And then we were looking through this stack of urine cultures, and there were some that just had R's all the way down. And I was the associate medical director at the time, and the medical director and I were talking, and we're like, we got nothing. We have no arrows in our quiver if this person gets really sick. We've got to do something. And so I read a algorithm that was a little less complex than the one that I just shared with you, that said, if you need 2 symptoms to get a UA, and one of them has to be localized to the urinary tract. So I implemented that in my building. And I did a couple of other things. I reinforced that upper respiratory infections were primarily viral, and unless they were very long, over 2 weeks, or a COPD infection with a lot of mucus, we weren't supposed to use antibiotics. So, and I reviewed with them some of the renal dosing. So each month when I would go through the antibiotic report, I would sit with my medical providers, and I never really, after I reviewed the standards, I never really told them what to do. I would just ask them, I see that you used azithromycin. Was it a COPD exacerbation, or did they have an upper respiratory infection? And they knew what I was saying, that if it was an upper respiratory infection, that was not what I was supposed to do. And I would ask about the symptoms of the urinary tract infection. I would ask for, nitrofurantoin. I would ask, tell me what the creatinine clearance was. That would reinforce that they should always check the creatinine clearance before using that drug. And just with my establishing standards and asking questions, I was able to essentially decrease the resistance to antibiotics within my building very effectively. I also wildly decreased the number of UAs. And pretty much everybody fought me on it at first because it was a culture change, but it was very effective at being able to decrease the amount of antibiotic use in my building. So the antibiotic timeout is now part of the code, but it's an excellent practice. That being said, it needs to be a multidisciplinary approach. So you need to be ensured that it is part of normal practice. I think that any patient who is on an antibiotic probably needs to be on report, and they need to be counting the number of days on report, and needs to be ensured that on day 48 and 72, that there is a reassessment by the team. And it can be an algorithm that's set out for nurses to say, is the culture back? Is the patient resistant to the antibiotic that is being used? If so, call the medical provider. Is the patient's still symptoms resolved? Can we consider discontinuing? It depends on what you have, if you have medical providers or nurses in the building, but you need to set up expectations for what that visit entails and meaningfully think about whether that antibiotic needs to be continued at that point. So, and then you want to make sure that there is adherence. So the IP would be double checking that those follow-up visits are happening anytime an antibiotic is initiated. And the medical director is also very useful at interfacing with other members of the interdisciplinary team and other specialties. So I think that it is very difficult to control prescribing if the nursing staff doesn't believe in antibiotic stewardship. So I like to talk to the nurses about the data and what's effective. The old time, we don't do 7 and 14 days like we used to. We do much less, and that many other, everything's not a urinary tract infection, and even how to communicate to the medical providers about potential urinary tract infections. I've had them say, I told the doctor that it was a urinary tract infection. And I'd ask, well, what did you tell the doctor? And he said, well, I told them the urine stank. And I'm like, well, you made them mad. That's not going to work. And you're going to need to give them one of the symptoms, like in the Loeb criteria or the McGear criteria, that they're looking for if you're talking about that, and teaching them how to communicate effectively. I really honestly believe that the center of quality, or one of the most important things to quality in the nursing home, is the quality of communication between nursing and the medical staff. So even teaching each other how to communicate about potential infections and changing condition can be incredibly important. The other thing is to communicate to outside providers. When I reviewed our antibiotic utilization data, I found a huge amount of dental antibiotic prophylaxis. And clearly these folks they did not have prosthetic valves or history of joint infections or or history of endocarditis. But it was a very big challenge. So I ended up penning a letter it was driven really by the dental hygienists. They were the ones who were very into it, not necessarily the dentists themselves. And I ended up writing them a letter saying that our building adheres to the American Dental Association standards for antibiotic use with dental care. And so we're going to be discontinuing antibiotics for anybody who is being used for outside of those parameters. And of course, every time I do this, nobody likes it. I had to communicate with hospice. When I implemented the 2 criteria for urinary tract infection, you'd think that they'd be on board, but they were not. And of course, I talked about establishing with the ED. I even had to I communicate with urology nurse practitioners. So I had a unfortunate event. My patient went to the urologist. They got a urine culture. And then the urine culture came back positive, which is, of course, 50% of the women in my practice in the nursing home. And they recommended Bactrim. And the patient almost went into complete renal failure as a result of that Bactrim. And I ended up interfacing with that nurse practitioner saying, given that we don't want to treat asymptomatic bacteria, and I didn't see any symptoms listed in your note, why did you recommend treating with an antibiotic? And so that's a lot of communication, and it's probably a medical director is in a good position to do that sort of advocacy for your building and advocacy for your patients. So I would encourage you to enlist them in the effort. Also, you may have some family education. Maybe you have family counsel, and you want them to let people know about your antibiotic stewardship program. I think that's also a very excellent use of a medical director. So medical directors are supposed to be good at data, and they're supposed to be good at quality assurance and process improvement. So one of the things that is part of any sort of quality assurance program is tracking your data. And I would encourage you to have run charts, which is the amount of infections or utilization, something to track your data to see how you are doing over time. All processes, no matter what they are, they will have a little bit of variation. I like this graph on the top here. It shows kind of this sinusoidal wave up and down. It has 4 lines that go in one direction and then right back down. That's normal. And it means that your process is likely just the same as it's always been. Nursing homes will get very excited about that 4-month trend, but it is not very exciting. It's statistically insignificant. And I think that looking at that with your medical director so that they can help you interpret that data and understand whether your process is genuinely changing, if you're trying to change it to, or not, or if it's just normal variation, is really important. So I think that they are your partner in, number one, in designing the tracking system, and number two, in interpreting that data. So this is a picture of the antibiotic tracking tool that we designed, and our QIO also took it, but it looks like Virginia's not in our QIO, but it's a multi-state. It's still on that website I shared with you, but we are able to, say which resident had it, when it was started, which antibiotic, why, did it meet criteria, how many days of therapy. This tool will calculate that for you, which is kind of a pain in the neck to calculate. Was it started in your facility or not? And which provider? Was it prophylaxis or treatment? And did they do the antibiotic timeout? And were there extenuating circumstances can be documented? So it really has all that you need. And it's generally run on a monthly basis. And you can see some of the reports. We can look at what type of infections you have. And this is something that's very useful and you can see facility-wide summaries of all of the antibiotic use. This also can break down into floor summaries. You may have differences by floors. Say somebody is trying to your behavioral floor and they're calling everything a UTI, that may be a trend that you would be able to pick out of this sort of tracking system. And you can also see provider variation and break it down to maybe you have a provider has a single go-to antibiotic, which I would highly discourage because you'll get resistance in your building with that. But that could happen. So if you had that, then you would be able to pick that out and talk with that provider about that prescribing pattern and the risks that it runs, or your medical director could talk to them. But the tracking, when you present the medical director and your medical providers with this sort of data, they can really go the next step with it. So antibiotic stewardship is part of your QAPI program, and it needs to be reported there. The medical director can help, as I talk, with reviewing the data, but they can also help with the root cause analysis. Maybe it requires conversations with the facility. My favorite was when I was a fellow. It took me a while to figure out what they were doing. But I came in to my floor at the nursing home one day, and everybody had smelly urine. I was like, well, what did you all do this morning? I was pretty confused. It was 9 months into my fellowship, but New York, I think at the time, had a Medicaid look back. And if you diagnosed, you didn't even have to treat them for a UTI, but if you diagnosed them with the UTI, they would actually be financially ahead. And it was the window, and they were trying to do that. But it took me a while to find the trend. But you can have random root causes. You need to go looking for them and why people are doing that. Is it associated with just a psych consult? Is your psychiatrist saying that every person with behaviors must have a urine? You need to look into any of those sorts of things. Then once you've done a root cause analysis, design an intervention, whether it's establishing criteria for getting a UA, changing an antibiotic, prescribing pattern, and then monitor the implementation and disseminate that knowledge, and then help review the efficacy and effect of your intervention. So the medical director is a partner in all of that. So then we have to prevent the infections, and you're probably tired of it because we're in vaccine season. And we've got a lot of vaccines to put together, but the medical director needs to be part of your vaccine protocols. And they have to help with timing of vaccines, looking at the data. We've got, if you've only got a limited amount of effort, can you co-administer certain vaccines? When should you administer the vaccines? We had 3 viral vaccines this fall. What's the most important? When can and how close can you put them together? The vaccine selection, I usually will help the IP select for ordering in the fall the number of preservative-free, single dose, the number of high dose, the number of normal dose vaccines that the building will need. We also set up non-patient specific standing orders. So in the RSV vaccine and some of the other ones are at that standard. I believe that the PCV20 is also at the shared decision making when it comes to if you've had the previous pneumococcal vaccines. So there, in shared decision making, the medical provider, the person recommending it, needs to be available to discuss and answer any questions as to whether that vaccine is right for that person. And the medical director can be a good resource for that. We were working on RSV and essentially, you know, going to be giving the families the information about the RSV vaccine, but also making available, if any had further questions, the medical director, they could contact me, the medical director, to review the risks and benefits of the RSV vaccine. I also, as medical director, serve as a staff vaccine counseling. New York had quite a strict mandate. If you did not get the COVID vaccine, you did not work in New York, and so there were no exceptions. And so there were many people who were hesitant, and I did group counseling, and some of that was efficacious. And some people I needed to do one-on-one counseling about the risks and benefits of the vaccine. And I think that enlisting the medical director in that effort can lend gravitas to the conversation and help. And then I was teaching my DON the counseling techniques that I found effective, and she would use them on other people, and we were sharing our counseling. So certainly working together and counseling the staff is very important. You also need to have emergency allergic response standing orders, epinephrine standing orders, adverse reaction reporting, staff education. They can help with it, and the fit testing protocols primarily. They're probably not doing your fit testing. I also figured out there weren't very many silver linings in the pandemic, but one of them was that all of the vaccines were getting in, being reported. And I suddenly had a tool that on tracking vaccines. We were always struggling, my buildings, with the pneumococcal vaccine. And we would call the previous PCP and try to get an answer whether they did or did not have the previous pneumococcal vaccine, but we weren't getting answers fast enough for our MDS purposes. And and I consider vaccines one of the most controllable QMs in your nursing home. So I got access for my IP to check our state database on vaccinations, and then we will check those on any new admission, look and see if maybe our medical record has some other ones. And if we don't find it there, instead of dithering around trying to get information back and forth from the PCP, which rarely worked, we'll just go ahead and vaccinate for those folks. So I find that to be very, very useful. And if you can participate in registering your vaccinations, I know it's a lot of work, but it is it is a tool that is so useful in the treatment of patients. In my book, it's really, really helped me be able to, because everybody was functioning off of memory. It was not working very well. So there's also infection precautions and isolation standards. And we have always needed to have a great deal of conversation around those standards. What do we do with people who are colonized? This is their home, they live here, but they also need care, and there's risks to the other residents and staff. So We, worked on the interpretation and implementation of enhanced barrier precautions. We work on education around masking protocols. Which masks should we stock? Can we keep up with the fit testing in this building, and the PPE, and discussions even where to put the garbage cans for PPE donning and doffing. All of those things are part of the work that is done collaboratively. We also, on colonized patients, when do you start and stop, or resolving isolation? When do you stop isolation for resolving infection? How to deal with open devices. Can they go out of their room? Can they participate in the activities? What sort of precautions need to be done? And also utilizing spreadsheets to monitor. I am the lab director, so for my buildings. So of course there's the CLIA waiver, and we work on testing protocols, and ensuring quality testing within the building. And then we also work on signage. I've been, this fall is quite a challenging time. I think that what happens is that people have got multiple viruses, not just one virus to contend with, and the standards are different and the risks are different. So we've been working on some of the signage to try to convey those risks clearly. And the medical director, of course, is very critical to outbreak management. They can help with contact tracing. I've looked at room layouts. I've looked at different things. I set up standing orders for testing and deciding how we're going to implement that. We are preparing a spreadsheet ahead of time on antiviral dosing so that it will speed us up if we're in the outbreak of either influenza or COVID. And we decide on prophylactic and treatments, prophylactic and treatment doses of antivirals. And we review the infection control procedures, making sure that, and cohorting decisions, I really have asked to be part of cohorting decisions. I've seen decisions made in homes that I'm affiliated with where I felt like the cohorting decisions spread the infection. And so I've asked, please, to, before people are moved, because usually they'll come to me after, before they're moved, let's just review that together and work together on those standards. I also prepare for outbreaks. In some of our buildings, we are consenting ahead of time for the use of antivirals so that we don't have to slow down. I help with the contact tracing. And these are also measures that when you're approaching your medical director, is important that you have done some of the work. So I had a scabies outbreak, and the entire facility, every nurse manager and all called me simultaneously on a conference call, and we're talking simultaneously about this scabies outbreak. And I could not get a straight answer out of them. Who touched who? And I kept saying it over again. Who touched who? And I was like, where's the IP? Because that would be my expectation as a medical director, is that the IP would have done some contact tracing. I will potentially ask further questions. Did, dietary touch the person? Who others? But I would expect initial moves towards contact tracing. I would expect the IP to look at the CDC recommendations, to Google, just like I'm going to Google to the CDC recommendations, so that we can talk about what's there together and how to implement it in our building together. And I would expect a line list of all the people affected to be created in the setting of an outbreak. So those are how to work with your medical director. And the medical director is important to ensuring appropriate treatment. I set up all of the orders and the protocols ahead of time and help to review, particularly Paxlovid is complex. And so I help to review the process. And in fact, I think you should prepare ahead of time on who calls the family, who runs the interaction list, who tells you how they swallow, and all of those things ahead of time before you actually have an outbreak, so that you know what to do when an outbreak occurs, because it'll happen. And then I meet regularly with my IP. We talk about vaccinations. Every time I walk in the building, I say, how's the vaccinations going? We talk about testing, when to test. Sometimes we'll discussion on whether to test on Thursday or Friday. I usually advocate for Thursday so that it doesn't all come back on Friday. We once we've done all of our homework, once we've looked into all of the things, we have an open conversation on how to engage in all of our infection control, antibiotic stewardship, and treatment things. So I would encourage you to collaborate with your medical providers. Many of them don't know what you need unless you directly ask for what you need. And then many of them, I would be surprised if they don't help. So, once they know what you need. But I don't think they come in knowing. A lot of medical direction is not something people are formally trained in. Very, very frequently, they've got very little training before they engage in the role. So there is some just being very direct about what you need that can help the situation. So with that, so the infection preventionist and the medical director have lots of roles they share and can work together on all of their antibiotic stewardship, the infection prevention with vaccines, cohorting, isolation, outbreak management, and infection treatment. Together, I think you can have the best outcomes. So with that, I am open to any sort of follow-up questions the group would have.
Wonderful. Thank you so much. We do have a question in the chat.
Oh,
that says, for nursing homes that could not create their own antibiogram due to lack of enough cultures, what would be the best alternative?
So I would be reaching out to your local lab and see if they do have one already, because they've got way more cultures than any one nursing home has. So that would be my first step. I would potentially collaborate with a hospital ID or infection prevention. They may be able to hook you up with the right people who are able to lead you to your antibiogram or a community antibiogram, because honestly, antibiotic resistance can run in communities too. So it's as close as you can get, because I do think creating an individual nursing home antibiogram is very difficult.
Absolutely, great advice. Other questions from the group? Feel free to unmute, ask your question, put it in the chat. Happy to answer those while we're waiting to see if any questions come in. I just wanted to kind of highlight one of the things that you said that I think was just so meaningful when you said that quality of care is quality of communication. I think that is just beautifully stated, that obviously quality of care is many things, but most importantly, one could argue, is talking with each other and really being able to be open with each other in terms of what we're seeing, what we're experiencing, what we need, and then how we can help each other. I think that was just a wonderful point that you made. So thank you for that. I did have a specific question. When you know, one of the challenges that we hear, that we face with antibiotic stewardship is trying to explain to perhaps the patient, the family, sometimes staff, you know, why are antibiotics not needed here? And so that conversation can be challenging. There can be, you know, pushback sometimes, and it can take a long time to have that conversation. I was wondering if you had kind of any tips or kind of pearls, little statements that you may use in those conversations. And then also you talked about the expectant management protocol. If you could tell us a little bit more about that.
So expectant management generally is, I'll just start there. That's pretty simple. If I was worried about something, a change in condition, I would be setting them up for regular vital signs over a time limited period of time and ensuring that they're being watched. And probably I would be pushing fluids. Anybody who's looking funny in a nursing home should have probably their flu. A little more water to drink. So when it comes to it feels like the nursing home provider is very alone many times in their antibiotic stewardship efforts. And a lot of people have pulled the trigger and said any change in condition, delirium. And honestly, I found many a person who's had delirium, and it's secondary to missing naps at the holidays, but it was blamed, a urinary tract infection was blamed. So I have to usually explain asymptomatic bacteriuria, that just because a culture happened, particularly in a nursing home female, or a close to nursing home female in the past, doesn't mean it was always a urinary tract infection. And that these, I believe in storytelling. And that's part of why I share, I talk about my patient who ended up, the dentist gave her 1 dose of azithromycin, and then she got C. diff and went on hospice. And I went to talk to her. I was like, why? I didn't give you an antibiotic. How did we get here? And I found out it was the dentist. And I talk about those sorts of stories, or the patient, like I shared with you, who went into almost full-on renal failure. So I said, I have to be careful with these medications. And many times I'm going to look very carefully. I need to be comprehensive. I've seen literally hyponatremia ignored because the physicians were not comprehensive in their evaluation. So I am not ignoring, I am observing, and I am trying to be very specific in my interventions. So I think that, so it is unfortunately a bit of long-windedness, but I do, minds are not changed with data generally. Stories do change minds. So I would encourage you all to use storytelling as a way to convey your message with a little data peppered in. So, but asymptomatic bacteriuria has rarely been explained to most of the families that we are working with. So that's new information. And so we have to share that with them.
Yeah, thank you. That's wonderful. Stories peppered with data. I love that. Wonderful. All right. Well, any other questions from the group? Again, either feel free to unmute or put in the chat. If questions come up afterwards, feel free to send them to us at the impact email, which Anthony's put into the chat, and we'll work to get those answered for you. Well, with that, thank you, Dr. Nelson, so much for joining us today and for sharing your stories and your experience with us as we kind of wrap up our series together here. So thank you for joining us. I also want to let you all know a couple of new resources that we have, or new opportunities that we have. VIPTA, the Virginia Infection Prevention Control Training Alliance, sponsored through VDH, website is now live. And so there's a lot of wonderful information there, a lot of great resources which you can search, calendar, which you can both search in terms of information as well as put your own events, submit your own events for that site. And so it's a really great resource that we have here in Virginia to use as a one-stop shop for infection control resources. So want you to direct you to that. Another opportunity, if you wouldn't mind going to the next slide, please, that we have. And so in the beginning, Anthony talked about, one of the focuses of our impact project is how can we optimize technology use in terms of care of our patients. And so we are happy to work with facilities about discussing telemedicine, how to optimize telemedicine, knowing also that there are a lot of places already that have implemented wonderful telemedicine programs and telehealth utilization within your facility. And so I wanted to highlight the Center for Excellence for Telehealth and Aging has an Innovative Practice Award. So where you can submit the process, the project that you've done at your facility, any outcomes you may have regarding telemedicine, and there is an award that is recognized twice a year that you could submit a submission for. And so the information is there. The deadline is November 24th. So if you want any more information about that, you can either check the website listed in the slides or let us know as well. So with that, I think next slide, please. All right, Anthony, you want to take it from here?
Sure, yeah. So that would be the slide that tells everyone how to claim their continuing education credit. I'll also include this in a follow-up email. And one other plug that I wanted to add, starting off next year in 2024 in January 17th, we're starting a mini series on long COVID, and we'll have a physician who runs the long COVID clinic at UVA address long COVID and during one session from a medical standpoint, and we'll also feature in a subsequent session physical therapist address long COVID from the standpoints of rehabilitation and functional implications. So it should be a good way to kick off the year with a COVID focus, long COVID. And then in between those two sessions, we're going to address some telehealth in the context of COVID. And so I think we have an exciting way to kick off the year for 2024. But I'll also include information on that in my follow-up email over the next couple of days. So thank you, everyone, for attending our final session. Thank you, Dr. Nelson. Really appreciate it. And everyone have a great day.
Have a great day. Hope to see you back in January.